So we'll go on to Module 1. I'm going to begin with the definition of gynecomastia and pathophysiology. But first, I'll just restate my title, which is Imaging of the Male Breast, or Is It Really Different from the Female? We all know there are many differences between men and women, and as it should be, and we're going to see how that applies to imaging of the breasts. I'm going to start with a context for you here. Here we have mammograms of two different men, both of who have a left breast lump. Which of these men has cancer and which has gynecomastia? Can you tell? This is a task which can inspire fear in a lot of people because we don't do as much imaging of the male breast as the women, so we worry that we don't know how to do it properly. So we're going to ask the question, are they really different, the male breast from the female breast on imaging? Well, the good news is that they are different in that the male breast is actually simpler because mostly we only see one diagnosis, which is gynecomastia. And they are similar in the sense that when we see cancers in the male, they look just like cancers in the female. So if you know how to look for cancers in the female breast on mammography and ultrasound, you know how to do it in a male. So if you approach it the same way, you can avoid the fears and the traps of thinking that you don't know how to evaluate the male breast. So how are we going to get there to this place of comfort where we can image the male breast like we do with the female? Well, first we're going to talk a lot about gynecomastia, which is male breast tissue in a male. We're going to talk about how it looks. Then we'll talk a lot about male breast cancer and how does it look. And then we're going to talk about how to differentiate gynecomastia from male breast cancer and how to avoid unnecessary biopsy and still not miss breast cancer. So our bottom line message is going to be to distinguish the rare cancer from the very common gynecomastia. We're going to evaluate the male breast tissue on imaging the same way that we do a female breast tissue. So now let's begin with what the normal adult male looks like if we do imaging. We're going to see prominent pectoral muscle here on the MLO view, large pectoral muscle on the craniocaudal view. We'll see a little bit of pectoral muscle sometimes as well. We have small nipples, like you see here. We have minimal subareolar ducts, just a little bit of tiny wisps there. And we see some subcutaneous fat, all the dark here under the skin, but no lobules. Men don't form breast lobules. So this is what a normal male chest or breast might look like. All right, now we're going to talk about the abnormalities. And gynecomastia is by far the most common that we will see. Number 1, number 2, number 3, all the way up to over 90% of the abnormalities that we see on breast imaging in a male will be gynecomastia. So the definition of this is a benign proliferation of breast tissue in men. Very simple. If we talk about the pathophysiology of gynecomastia, we can break it into two types, depending on whether we are lumpers or splitters. We can talk about pseudogynecomastia, which means it's not true gynecomastia. And in pseudogynecomastia, we see only fatty enlargement of the breast, just excess fat tissue. True gynecomastia, on the other hand, we see also proliferation of the breast ducts, of the breast stroma, and the supporting tissues like the vessels. But again, we see no lobule formation. Women form breast lobules, but men don't, almost never. And we do see a component of edema in gynecomastia as well because there is some inflammation. Here you have a slide which shows these pink rings, which are cross-section of the ducts. And this is the ductal epithelium that we see here. And we see the surrounding stroma, the loose connective tissue here, and the extracellular fluid that reflects a little bit of edema. So this is what proliferation of breast tissue would look like in a man on pathology. Okay, true gynecomastia is very often physiologic, and there are 3 times in the life of a male when we can see physiologic gynecomastia. First in the neonate, because of transplacental estrogen. There is a little bit of stimulation of the breast bud, so little baby boys can have a little breast bud, which goes away. Then again, in adolescence and puberty, there is hormonal imbalance, which stimulates the breast tissue. And these adolescent boys can get some gynecomastia, as in this case, and that usually resolves as well. Then third, around middle age and older, there's hormonal flux with changing testosterone levels in normal men, and so they can have a little gynecomastia at that point as well. So in addition to physiologic or idiopathic gynecomastia, there are other causes of true gynecomastia, and this is in order of frequency. So the most common other cause is drugs, and we'll talk about which drugs can do this. They also have systemic diseases, and these diseases are all characterized by the feature of altering hormonal metabolism. So there's increased estrogen circulating, usually because the estrogen clearance is being decreased by liver disease or renal disease. Third on this list is much more rare primary hypogonadism and Klinefelter syndrome. We'll talk a little bit more about that later. And then last, the least frequent, is various kinds of tumors that can cause hormonal changes. So we'll talk about drugs first. This is a list of some drugs which commonly cause gynecomastia. A lot of heart drugs like digoxin, thiazide diuretics, spironolactone cause gynecomastia. Drugs used for stomach ulcers and reflux like H2 blockers and proton pump inhibitors will cause gynecomastia. Similarly, tricyclic antidepressants can do it. One of the most potent effects we see is when exogenous estrogen is given in men treated for prostate cancer, and we see the most abundant gynecomastia in these patients. Most commonly in young women, though, the cause is marijuana. And then also in bodybuilders, we see it a little bit less than we used to because they've figured out how to counter the effects, but bodybuilders will use anabolic steroids, the DHEA, which is the dihydroepiandrosterone, which can cause gynecomastia as well. The steroid metabolism is very complicated. I'm not going to go into all of it, but this is my simple version that helps me remember. And we keep in mind that estradiol is the most potent estrogen, the one that causes gynecomastia the most. And testosterone can be converted to estradiol through the enzyme aromatase. Therefore, if a man has gynecomastia, you can use an aromatase inhibitor to counter this effect and prevent this conversion from testosterone to estradiol. So bodybuilders that use the DHEA, they have conversion of this drug to estrone, and then estrone becomes converted to estradiol. So we end up in the same place with this strong stimulating hormone of estradiol. Okay, now we're going to move on to some other hormonal conditions that can cause gynecomastia. We mentioned Klinefelter syndrome. This is one of the most common genetic conditions that we see in boys. It's the XXY chromosomal defect. And this affects development of the testes. So these boys and men have overall less muscle, less hair, all features that testosterone modulates. So higher estrogen levels, more gynecomastia. And interestingly, for these men, they have a higher risk for all kinds of cancers, but particularly for breast cancer. So a male with breast cancer has a much higher risk. A male with Klinefelter's has a much higher risk of getting breast cancer, about 15 to 60 times, depending on which studies you read, compared to other men. So if a gentleman has Klinefelter syndrome, we do want to have a higher level of suspicion for breast cancer in them. Other neoplastic causes of gynecomastia are adrenal tumors, pituitary adenomas. These affect, again, the balance of estrogens, circulating estrogens, hepatocellular carcinoma and testicular carcinomas also affect the hormone levels, circulating hormone levels, and then very rarely HCG. HCG can be produced in lung cancers, liver cancers, kidney cancers. This is an example of gynecomastia, bilateral gynecomastia in a male with a pituitary adenoma. This is a rare cause. You can tell it's the only case I've ever seen in my practice. It's a very old slide. You can still see the scratches from the digitizer when we put the films in to convert to digital images when we started doing PowerPoints. But this is the only example I have of a man with a pituitary adenoma causing gynecomastia. Okay, so we've talked about all the causes of gynecomastia. How frequently are they seen in the typical clinical practice? Well, you can see here that the physiologic or idiopathic gynecomastia is responsible in about 50% of time. Then drugs as a cause of gynecomastia adds another 10 to 20%. So if we take these two together, physiologic or idiopathic and drugs, we're up to about 70% of patients. Then you can see a much smaller contribution is by patients with systemic diseases like cirrhosis, malnutrition, primary hypogonadism, testicular tumors, and other. So these very small contribution. So how is it that these patients come to us as breast imagers? Which of these patients are we going to see? It's helpful to look at the algorithm that the primary care docs use to diagnose gynecomastia, because you'll see how this plays out. So the primary care physician sees a patient who appears to have some breast complaint. They do a physical exam and they assess whether they think the patient is actually normal, in which case they won't do anything. If they think a patient just has fatty hypertrophy of the breast, if they have pseudogynecomastia, then they may counsel the patient about weight loss or something like that. If on exam, they think that the patient has true gynecomastia, and usually they conclude this by seeing that the symptoms are bilateral, they're symmetric, then they can diagnose that pretty confidently as benign gynecomastia, and then they begin their search of various causes to see what could be causing it. And none of these people really need imaging. One of the things they look for is the testes. Is there a testicular tumor? So that would be their next step. But then those patients who present with a palpable mass, and that usually means a lump in one breast that's different from the other side, these are the patients that come to imaging because the primary care doc is unable to say this is benign gynecomastia because they don't have the typical bilateral symmetric appearance. It may be gynecomastia. We know that it often does present as asymmetric or unilateral, but the clinician can't tell that, so they then request imaging. So for any suspicious mass, the patients are going to go to imaging, and that gives us the impression that gynecomastia is more often unilateral or asymmetric. But that's really just the population that we see, because the ones that are bilateral and symmetric often don't even come to us as imagers. So thank you. We will move on to the next module in a couple of seconds here if you're still with us.